My name's Stacey Menton. I'm a speech pathologist at Mayo here in Jacksonville. And I am really interested in how speech pathology can help patients with hypermobility spectrum disorder and hypermobile Ehlers-Danlos syndrome. And I do work with the EDS clinic at Mayo. And I have started giving this specific presentation to our EDS living program. But considering I just started doing that yesterday, I am assuming that pretty much nobody's seen it yet. I want to talk a little bit about what we're going to talk about today. So we want to recognize typical voice, upper airway swallowing, and cognitive concerns in the hypermobile population, explain ways to care for your voice, upper airway, and swallow mechanism, and know where to go when professional help is needed. I forgot to mention earlier, you guys have questions while I'm going through, feel free to just blurt them out. It won't slow me down. All right, so first we're going to talk about my favorite part of the body, which is the larynx. The larynx is responsible for breathing, swallowing, and voicing in that order. So we're going to talk about each one of those things a little bit more in detail. So first we're going to talk about breathing. You'll see this lovely picture on the right side of the screen with the lungs and the airway, and then on top is the larynx. The larynx kind of helps guide air in or out of the airway coming up into the throat, and it can stop air or it can open up and let air come through. Air is what makes our vocal folds vibrate. There are a lot of muscles involved with breathing. Probably the most important one is the diaphragm, which is a dome-shaped muscle that sits just right underneath of the rib cage, and it goes front to back and side to side, and it attaches to the spine as well. And then we also have these fun little muscles in between the ribs that are called the intercostal muscles. You have two sets of these. You have the internal intercostals, which help with exhalation, so they pull the rib cage in. And then you have the external intercostals, which pull the rib cage out, so they help with inhalation. The abdominal muscles and the accessory neck muscles are also helpful in breathing in some cases. The abdominal muscles allow for really nice low breath. Low breathing can actually help stimulate the vagus nerve, which can help with the rest and digest portion of the nervous system and kind of get you out of fight, flight, or freeze. So low breathing is the name of the game there. And then the accessory neck muscles, if you're really short-winded, we tend to start using lots of these muscles. Now that takes us out of rest and digest and puts us into fight, flight, or freeze, which can be helpful if you're trying to wake up. But otherwise, I usually recommend avoiding really high breathing. I want to show this fun little video really quickly on the art of breathing by Jessica Wolf. This is just the demo that's on her YouTube channel. And it kind of demonstrates how breathing works. So what I want you to know is that on this demonstration, the blue is the cartilage, diaphragm is pink, lungs are a purplish color, and other muscles are magenta. And it gets loud sometimes. All right. So you can see the rib cage kind of moving in and out. So here it's coming back in and then out. They'll show you from every angle, which makes it a little bit easier to understand how the rib cage and the shoulder blades are moving with breath. This is the best muscle ever. This is the diaphragm. So it descends when we breathe in, and then it comes back up when we breathe out. This muscle does not fatigue, and it's not really under conscious control. And then there are the intercostal muscles added. They're a pretty good demonstration of the externals and internals there. So now let's talk about what can go wrong with breathing for the voice. So inducible laryngeal obstruction is the newest name for a condition where the vocal folds close when they should be open for breathing. So inducible laryngeal obstruction, the old names for it were paradoxical vocal fold movement or laryngospasm, vocal cord dysfunction. Those are the three ones that you might have heard of if you haven't heard of the newest one, inducible laryngeal obstruction, which describes it better. Essentially, the vocal folds are supposed to open up when we breathe in, and then they're supposed to close when we exhale if we're talking. But sometimes, for some reason, and we don't know why, I have my suspicions, but we don't know why yet, the vocal folds suck in, and that will cause a sound to happen on the inhale, like this. And it feels like you're having an asthma attack. Like it's commonly misdiagnosed as asthma. Other times it's misdiagnosed as anaphylaxis. So people come into the emergency room and they're doing that and they're like, oh my gosh, their airway is closing up. Well, their airway is closing up, but it's the vocal folds. And if a good emergency room doctor doesn't see you and say, oh, this sounds like your oxygen saturations are normal, they shouldn't be if it's anaphylaxis, like anaphylaxis with swelling in the throat. Because it turns out, I just learned this last week, anaphylaxis is not necessarily just mouth and throat swelling. It's like it requires two systems or something. There's an allergist on the Hypermobility MD podcast. Yeah. I think inducible laryngeal obstruction is related to MCAS. And so I'm doing some of the research on that right now, trying to figure out if we know that inducible laryngeal obstruction is more common in our EDS patients based on the paper that we published last year. And so the question now is, what's causing it? If it's so much more prevalent in this population, why? And so we're trying to kind of tease out just from questionnaire data who is potentially an MCAS sufferer from the questionnaires and who is an ILO sufferer, and see if there's a huge intersection between them.
Yeah, because I don't get the other ones have like a bug reaction.
Yeah.
I've never had like an asthma type, but I've had what you just said.
Mm-hmm.
And I've had a lot of those, but it doesn't.
Yeah. Yeah. So the good things to know here is that if this happens to you, there's a brainstem response associated with sniffing that will automatically reopen the vocal folds. So all you have to do is, and then exhale on a shh. The SH or the pursed lips, both of those provide a pressure feedback that keeps the vocal folds open on the exhale so that you don't end up in a cycle. And if this is
so cool. We had Christy over last night and I was doing this and I'm coughing and doing like, I just like quit breathing. And I would like say like, this is this weird, like allergic cough thing that I get. And I don't know what else to call it besides an allergic cough thing.
Yeah. How long does it last?
It can last from 2 minutes to 30 minutes.
All depending on how you react to it, right?
Yeah, like if I freak out, it can last 30 minutes.
Yes, exactly. So what was that? That could be part of it too. So that can absolutely bring that on. So if something goes down the wrong way, that's going to be a trigger. But for some people, it smells. So like chemical smells, perfumes. Yeah, perfumes, chemical smells, hot air, humid air, cold air, dry air, just depending on what your triggers are. Air blowing on you in the car specifically, that one triggers me. So
I've had so many doctors say that I don't have bad swallowing, and my wife Crystal will say, oh, that's that thing you don't do, babe.
Interestingly, we're going to talk about swallowing in a few minutes, but swallowing will also, we've seen a lot of swallow complaints in this patient population. And I've been talking, I've kind of created a group of speech pathologists who are interested in treating patients with HEDS and HSD across the country, and one person in London. So we're calling it an international group. But he feels like we have to be a little bit slower. And he's right. I mean, we found that just like with physical therapy, we have to be slower in how we advance patients. But with the swallow, think of food as weight. So if you're not tolerating a full diet, you need to slowly increase the weight. You don't want to go from like not eating very much to eating way too much. And recognize that sometimes you need to like decrease how frequently or increase how frequently you're eating so that your muscles have time to recover. And we'll get to that, I promise. I have more to say on that.
I'll quit
Go ahead.
interrupting. Thank you, Stacey.
Absolutely. If you're having this inducible laryngeal obstruction thing, feel free to reach out to a speech pathologist who is a voice specialist. We have 2 of us at Mayo. It can be a bit of a pain to get in to see us, but I'll make sure that my email address gets added somewhere so that you guys have access to it. Because if you just email me and say, hey, I'm having difficulty getting in, I can at the very least reach out to the people who you would be talking to and be like, hey, we need to figure out how to make this happen. Usually to see me, you need some kind of a physician to say that you need speech therapy. That's at the very least, but we continue to encounter issues at Mayo with them saying, oh, well, you need to see a doctor first. And there's argument as to whether or not that's true. All right, so the other thing that can go wrong with the upper airway is cough. Chronic cough specifically. So a normal cough where something goes down the wrong pipe, or you know, you're just getting over being sick. Your body is protecting your airway. That is what cough is meant to be, is a protective mechanism. But if your cough just gets worse and worse and worse, or it just sticks around forever, there's a couple of different reasons that might be. Reflux is one of them. But we really need to fully evaluate at that point allergy, reflux and GI issues. Pulmonology needs to kind of be involved. And then ENT kind of comes in at the end, because chronic cough where it's not related to some underlying condition is something that a speech pathologist can treat, or my colleague, Dr. Rutt, will do steroid injections into the superior laryngeal nerve, which is so like a couple of needle pokes in each of these spaces here, and to kind of calm down the superior laryngeal nerve, which is a branch of the vagus nerve, and it's known as the cough nerve because it feeds sensation to the voice box and some of the surrounding tissues. If the hypersensitivity of the nerves is the cause, then the treatment would be with either the speech pathologist or Dr. Rutt, or a combination of both. And that's really patient specific, so whatever the patient wants. All right, let's talk a little bit about swallowing. So over here on the right, you'll see that there are different phases of the swallow, which is what we're going to start by talking about. So there are 3 phases of the swallow. There's the oral phase, so in the mouth, the pharyngeal phase, which is in the throat here, and then the esophageal phase, which is when it goes down into the esophagus, heading down towards the stomach. The blue here is the airway. So what I want you to see is how close the esophagus and the airway are. So for you to swallow, I think I have this on another slide next. I just want to show, for you to be able to swallow, there's this bone called the hyoid bone. It's the only floating bone in our bodies except for our kneecaps. It doesn't attach to any other bones, but it attaches via connective tissue to the base of the tongue and then to the voice box, the larynx, which is a ton of cartilage. The hyoid bone is supposed to move kind of up and forward when we swallow, which closes this fun little thing called the epiglottis, which is a piece of cartilage that folds over the airway in the front so that the esophagus in the back can open and food can go down into the esophagus. But that's a lot of coordination that needs to happen. So discoordination can happen in a couple of different places. So first, the soft palate, which is this piece of tissue here, is supposed to close off your nose when you swallow so that things don't come up and out your nose. sorry. And then the hyolaryngeal complex that I was talking about is supposed to move up and out of the way. If that doesn't move at the exact right time, and in the exact right distance, there's the possibility for things hanging out in the throat. And then the esophagus is supposed to open up and things aren't supposed to come back up from the esophagus into the throat. But you can see how close the esophagus and the airway are. So if things come back up from the esophagus, they can spill over into the voice box, and that is the top of the airway. So at that point, you're at risk for aspiration, which is something speech pathologists are always very afraid of, because aspiration that happens a lot can lead to aspiration pneumonia. So our goal is to try to re-coordinate the swallow a bit and to recognize what's going to work best for you. So at Mayo, we do a thing called a fiber optic endoscopic evaluation of swallowing usually, which does involve a scope going through the nose and looking down at the throat, but it gives us the ability to feed you things that are dyed green. We can see if you're gluten-free, we have gluten-free products. Usually it's a graham cracker is the solid. But we also have some gluten-free cookies. And then we have applesauce and 3 different types of water, 2 of which have thickener in them so that they become a slightly thicker consistency. And we can see how you're swallowing in your mouth and throat. We can't see your esophagus at that point, but we can see if things do come back up. We can see how things are moving in your throat, and then we can, you know, kind of determine what the best treatment is for your specific swallow issue. All right, so then voicing. This is the third thing that the larynx is responsible for, and this is my favorite thing because voice is the reason I got into speech pathology. My undergraduate and my first master's degree are both in voice performance and pedagogy, so I'm an opera singer as well. So singing was the reason I got into speech pathology. And here you can see 2 little vocal folds. They're the white ones. Those are your true vocal folds or vocal cords. And then you have some folds of tissue here. These are called the false vocal folds or the false vocal cords. They're really meant to be an additional protective mechanism for the swallow, but sometimes the brain will start to use them to make the voice happen, and they'll make the voice sound a little bit more strained. But we're going to talk about the 3 subsystems of voicing. So the first subsystem is respiration. So air comes on the exhale through the lungs, past the vocal folds, and that air pressure is what sets the vocal folds into vibration. And that's because when we go to talk, the vocal folds kind of come closer together, and they're not touching yet, but the airflow coming through them actually sucks them together. And then they pull themselves apart because they're elastic. And that is phonation, so the actual vibration of the vocal folds. We want that to be nice and free and loose. The vocal folds under a strobe light should look like they're little ocean waves happening across the top of the vocal folds. If they get stiffer, that can also cause some rough vocal quality. And then we have the third vocal subsystem, which is resonation. So the air comes up through the mouth, throat, and nasal passages in such a way to make our voices our voices. Everybody's structure is just a little bit different, and everybody holds their structure a little bit differently, which is why we have so many different, like everybody has a voice print essentially. But the goal there is that we want everything to be nice, free, and loose, and creating a bigger space. Bigger spaces, kind of like going to a cathedral versus going to a room with like carpet and ceiling tile. Although this room has carpet and ceiling tile and it's amazingly resonant for that. I'm actually surprised. But usually carpet and ceiling tile would pull in a lot of the sound. We want that big cathedral space. So that's one of the things we work on in voice therapy, is to change resonation and breathing to re-coordinate the subsystems when things go wrong. So vocal fold movement. So the vocal folds sit right at the top of that windpipe, and they're fixed in the front here. And then the arytenoid cartilage is back here, open and close. And then these are supposed to vibrate. This little video just demonstrates that sometimes they don't vibrate as big as they're supposed to. So it'll show you what normal should look like. is the white little dotted line, but you can see in this case, this person's vocal folds are not opening and closing as well as we would have liked them to. So that's one thing that can go wrong with the voice, is the vocal folds don't vibrate as big as they should because they're stiffer for some reason. Another thing that can go wrong is you can get little bumps on the vocal folds, which affect vocal fold vibration, make the voice rough. You can also, I've seen actually in my hypermobile patients, the thing we see the most is muscle tension dysphonia, which is by and large the thing I treat the most in my hypermobile patients at Mayo. And the goal with treatment of that is just to realign those subsystems so that they're working properly. Sometimes we'll see patients have a paresis or a paralysis. I am usually questioning whether they actually have a paresis or paralysis or if they have an arytenoid subluxation. So the arytenoids in the back, these little cartilages that are attached to the vocal folds, they sit right on top of another cartilage called the cricoid cartilage. And if they kind of fall off that, and we know that subluxations are more common in our hypermobile patients anyway, if they fall off a little bit, it can look like a paralysis because it's not moving, but it's not moving for a different reason potentially. I no longer recommend considering closure of the vocal folds, like with something to plump up the vocal folds. I don't always see, we don't always see the best results with that because things can start moving again. They can pop back in. So usually the treatment is voice therapy and trying to figure out how to strengthen the muscles to keep everything in line, which I'm currently working on figuring out a protocol for that. It's not easy, but we're trying to get there. Okay, and then the last thing to talk about that a speech pathologist might treat is cognition and executive function, specifically the executive function piece. Executive function can be addressed by lots of different practitioners, which we'll talk about in a second. But let's go over what executive function is, because I think it sounds like something that, you know, somebody in a big business office does, but it's actually something we all do every day. So self-awareness, inhibition, non-verbal working memory and verbal working memory, emotional regulation, motivational regulation, planning, and problem solving are all executive functions. So the ability to make a plan, determine do the plan and actually like avoid doing other things, and then being able to determine, did the plan work? And then going back and trying to figure out how to tweak that. Is not always easy for many people, but hypermobile people as well. We know that there are common comorbidities in EDS of autism spectrum disorder, attention deficit hyperactivity disorder, and myalgic encephalomyelitis or chronic fatigue syndrome. All of those things can affect cognition. Now, especially in the case of chronic fatigue syndrome, we need to get the chronic fatigue syndrome better under control before we can really address cognition. But in terms of in terms of ADHD and autism, those things are treatable sometimes by a speech pathologist, other times by a mental health provider, and sometimes by occupational therapy. It all depends on what your deficit is. So seeing one of those people and saying, hey, here's the problem I'm having. Are you the right person, or should I go see one of those other providers that might also provide that service? So let's talk about how to take care of all of these 4 things that we just talked about. So taking care of your breathing. You want to try to breathe through your nose. Nasal breathing is amazing because for a lot of reasons. If you want to learn about how amazing nasal breathing is, there's a book by James Nestor that I know the library has because that's how I read it. It's called Breath. And it goes through all of the different things about why nasal breathing is superior to mouth breathing. You also want to work on that low breath pattern to activate the vagus nerve so it calms your system down, turns on the parasympathetic nervous system. I always get those two confused. But the rest and digest part of your nervous system. And then make sure you're always good with hand hygiene to avoid getting sick, because that will obviously affect your breathing. taking care of your swallowing. So you want to make sure you chew well. I don't remember who said it, but somebody said something like that you should essentially drink your food because your food should be so smooth that when it goes down, it's almost like liquid. So make sure you're chewing well because it'll make it easier to digest and easier to swallow. Attend to your swallowing. So if you're out eating with somebody, avoid talking while there is actually food in your mouth because that discoordination is more likely in the hypermobile population. So trying not to eat at the same time as you're talking. Finish swallowing and then you can talk. I promise people will wait for you. The other thing you can do is an oral hold. So this would be where you put the, food or liquid in your mouth and you hold it without transferring it back until you're ready. So this becomes a conscious swallow instead of this subconscious thing that we usually do. And then, like I said before, smaller, more frequent meals, especially if you have reflux. With reflux, if you eat smaller, more frequent meals, you're less likely to reflux. There's also a supplement that I love called Reflux Gourmet. I make no money off of recommending it, but it was created by 2 different laryngologists and a chef. It's a what would we call this? It's like a syrup. Yeah.
Can you repeat that?
Oh, Reflux Gourmet.
Gourmet. Okay, thank you.
Yeah. So it's like a syrup that you can get. The only place you can buy it is Amazon. The 2 laryngologists and the chef that made it didn't want to go into the distribution business. So they elected to let Amazon do their distribution. But it is I usually tell people it looks like a goo. They have mint chocolate and vanilla caramel. I prefer the vanilla caramel personally. There's a slight salty aftertaste because it's made from seaweed. And so the slight salty aftertaste to me goes better with vanilla caramel than it does with mint chocolate. But what it does is it creates this raft above your stomach contents so things don't flow back up. So if you're having a reflux issue and you've tried all the reflux meds that are out there, this is something I frequently recommend. The only thing I would suggest is make sure that you look at the list of ingredients and make sure that they're not something that you react to. Yeah. I had one patient who had a grapefruit allergy and it has grapefruit oil in it. So she couldn't take it anymore, but she gave it to her husband. She said it was fine. But yeah, so reflux is something to kind of take care of, but there's question as to whether or not like who's in charge of reflux because GI is technically where that sits, right? But it comes up into the larynx, so up into the throat, which means that then becomes an ENT problem. And so we see a lot of patients with reflux, but reflux is often overdiagnosed by ENT doctors. It's a problem that the ENT profession is trying to correct, but it's still in existence. If they can't see anything wrong with your vocal folds, they say, oh, you must have reflux, and they treat you for reflux. Whereas the GI doctors are like, no, we need to test and make sure that you have reflux before we just start treating empirically.
How does that play into if you have a hiatal hernia? Yeah, so hiatal hernias are basically just the stomach has come up through the diaphragm, right? Yeah. So that puts you more prone to have reflux, but the reflux gourmet should still be helpful in those cases. Okay. If you experience a lot of symptoms where you feel like your throat clearing a lot and things like that, the reflux gourmet is supposed to be taken, I think, after every meal and at bedtime, so that'll keep things down. But the concern with reflux that comes up higher isn't just the acid that comes up. It's this enzyme in our stomachs called pepsin. Pepsin's an enzyme that helps digest animal protein, which is fabulous in our stomachs because as humans, we have a tendency to eat animal protein. So the goal is to kill off the pepsin because the pepsin, once it gets up here, recognizes your muscle fibers in your throat as animal protein. So it binds to them and starts to digest them, which can cause the irritation in the throat that we see sometimes with reflux. So at that point, the recommendation that I usually make is to trial some alkaline water with a pH of 8.8 or higher. I do not like alkaline water for things to like alkalinize the blood. They're not going to do that. Yeah. But alkaline water can kill off pepsin. There's a decent study by Dr. Jamie Kaufman, who's a laryngologist up in New York, that water with a pH of 8.8 or higher was shown to deactivate or stop the pepsin in test tubes. And I have had a lot of good anecdotal evidence from my clinic. I've been at Mayo now 9 years, and I've been recommending alkaline water for like 8 of them. And I've had numerous patients come back and be like, this changed my life. So alkaline water, you can buy it at the grocery store. Don't spend $1 million on Essentia. You can get cheaper ones at Publix. Yes, Christy.
I get the gas, but not the reflexing.
Yeah.
I get and the Tums and the Rolaids and stuff don't work. But a teaspoon of baking soda in water and I swallow it.
That's alkaline water.
That's why I was just.
Yes.
Surprised that was alkaline.
Yeah, yeah. So you're turning it into some kind of alkaline water. You can't, it's hard to test the pH of that, obviously, but
That's also good for intermittent fasting, and you have to like, because it says for helps to digest, relieve hunger pains. Is that like
interesting.
relieves hunger pains and fasting? Would that be those air hunger pains? Yeah.
That's a good question. I don't know the answer to that.
You get air hunger?
Oh, I do. Yeah. Like when I first wake up in the morning, I get angry until it goes away. Yeah.
Which way are you?
So Publix has a brand called 10 that I have found to be fine. Sometimes they have 10 purports to have a pH of 10.0. Some of my patients and some of my voice students and even myself, sometimes the texture is a little bit different than regular water, but it doesn't taste quite the same as like baking soda and water. So you can't tell as much, because what they've really done is added different kinds of salts, but not sodium chloride. So they're adding like potassium chloride, magnesium chloride, and one other one. And when they add those, that changes the pH of the water. So like smart water, which if you've ever had that, that's a little bit smoother than regular water. And it's a little bit thicker. So you're going to notice that. What I usually say is if the thickness of it really bothers you or the texture of it really bothers you, make it colder. It makes it a little bit more palatable at that point. Okay, and then how to take care of your voice. So hydrating. We used to tell people that they have to drink like 64 ounces to 120 ounces of water a day. It turns out that that's not necessarily the case. Everybody's a little bit different in how much water they need, but the general rule should be drink when you're thirsty and drink mostly uncaffeinated liquid. Ideally uncarbonated liquid as well, because we want to try to reduce the acidity of things because of the reflux thing we were talking about earlier. And then make sure that your urine is a light color. So it should be very pale yellow, maybe even clear. As long as both of those are true, you're hydrated. Your body's really good at siphoning off hydration by changing how much water goes out with urine output. So when your urine is clear, there's more water it feels that it can let go. The second thing would be vocal pacing. So thinking about, hey, I have this thing coming up that I'm going to talk a lot at. So I'm going to stay quiet for the 15, 20 minutes, hour beforehand. And then I'm going to try to give myself 20 minutes after where I can be quiet as well. It doesn't mean that you're actually napping, but you're taking a vocal nap. And the idea there is just to give these tissues that you're using all the time to recover. The third thing listed here is to avoid whispering, which seems counterintuitive because you think that was somehow protecting your voice. So we tend to whisper like this. And when we whisper that loud, we're actually straining to create a louder sound. And then our brains can learn that motor plan and start to try to use that motor plan when we're talking. And that's when muscle tension, that's one of the things that can cause muscle tension dysphonia to ensue, is that the brain just learns a new motor plan for one reason or another. And then we have to change the motor plan again. And then the last thing is straw phonation. And I forgot to bring a straw. But essentially you want to put a straw in water with like this much water in the cup, and you put the water in, you blow bubbles, and then you turn your voice on with the bubbles. So you're going, ooh, and you want to keep the bubbles going. And you only want like an inch or two of water, because more than that is gonna create too much back pressure, and that can get really uncomfortable. And then you can do like a glide up and a glide down. So 3 hills, and then like a little song like happy birthday, and you can finish the song off. And then this is a really good reset button for the voice. You can also do it with something called blowfish, which I love, but it's harder to train. So it's essentially like puffed cheeks, and you're letting just a little bit of air through your lips like you're blowing up a balloon. And then you turn your voice on with that. Exactly. Good job, Christy. And then you can hum happy birthday and things like that too. And then finally, taking care of your cognition. So this one is a bit more general, but keeping your mind engaged. I should also mention cognition is definitely not my specialty. It's something that I did deal with traumatic brain injuries back in the Philadelphia area before I moved down here. But again, that was like 9-10 years ago. So I've been out of practice for a little while, but we do have some other SLPs and OTs at Mayo and mental behavioral health professionals who also address cognition. And there are fabulous ones outside of Mayo too, I should say that too. But ideally you want to keep your mind engaged, make sure you're taking care of your whole body, like nutrition and physical movement and all of the things, because the more you take care of your whole body, the better our minds tend to feel. Address physical and mental health, understand how your medicines can affect your cognition. Along that same line, understand how medicines can affect your voice, because they can do that too. And then seek care from a speech pathologist, occupational therapist, or a mental health professional if you feel like that's needed. This is just my fun little plug. This is the awesome team that I work with at Mayo. It's myself and Dr. Chandler Thompson, Dr. Amy Rutt, and Kathy Murray, who is our nurse. If you're having a voice issue especially, please feel free to come see us. The upper airway and the cough piece usually take a referral in from a Mayo physician to get to me and Chandler. And the EDS clinic as well as the cough clinic have both been known to refer into us. So if you're having those issues, please feel free to reach out to them first. And then I'll open up to any additional questions that anybody might have.
So Stacey, I have a really hard time with palate discoordination and things going into my nose when I eat. Mm-hmm. What can I do to help that?
Well, so there are some strengthening exercises you can do, like holding your breath where you feel like air is not coming through your nose might be one thing you might do to try to strengthen the palate.
Okay.
Because that should close off the nose that way, so you're strengthening it a little bit. The other thing you might consider, if it gets to the point where it's like every meal all the time and like you're getting infections in your nose from it, they do make some prosthetics that you can put in to kind of hold up the palate. These are not always easy to tolerate because the gag reflex can kind of get inhibited or can get like triggered.
Okay.
But at that point you want to see a prosthodontist. You could also ask for a swallow evaluation at Mayo, or honestly any speech pathologist can do this. Swallow therapy is really kind of, SLPs frequently do swallow therapy. You can find good SLPs at Baptist, at St. Vincent's.
Well,
Mayo.
I've done like manometry, and the last one I had 20% not normal.
Mhm.
And they said, well, 20% isn't enough to say that you don't have normal. And that's all they said.
Well, that's not how, the manometry is not going to do anything about your soft palate though.
Okay.
So
Well,
if it's the soft palate and things going into your nose, what actually would probably be the most helpful kind of test for that would be an X-ray test of your swallowing called a modified barium swallow study, which
yeah,
are done
that,
in radiology. Have you had one of those done before?
yeah.
Okay. With a speech pathologist?
Yeah. And that one showed some back stuff and some abnormal stuff, and they just said, well, there's not a whole lot of dysfunction, but there's some dysfunction. It was
So,
just like, oh, thanks. That's awesome.
yeah. So I mean, I know at least where I work, I have been doing a lot of work with my neurology SLP colleagues just to make them more aware of the EDS population, and that things look mild when we evaluate, but that doesn't mean that they're having a mild problem. That,
So my
yeah.
last modified swallow was a year ago. I don't
Okay.
know how often insurance pays for those things,
Fairly frequently, surprisingly, but I don't
Okay.
necessarily know if nothing's changed since then. Do you mind if I
Nothing's
ask where you got
gotten
that done?
better, for sure.
Where did you have that one done, if you don't mind my asking?
That one was Baptist.
Yeah. So Baptist has an agreement with we use the same software
Yeah.
at Mayo, Baptist, and I think St. Vincent's recently switched to them too. So because we use the same thing, we can frequently at least see the written reports.
Yeah.
If you can get a copy of the disc, you can bring that to any speech pathologist that you're comfortable with and say, hey, here is my problem. I need, and your doctor can refer you in for a swallow evaluation, like what we call a clinical swallow, for somebody to kind of re-review your X-ray test that you had done last year. Because if nothing's changed, then it doesn't warrant repeating necessarily, in my clinical opinion.
So I can have my primary refer me to you?
To me is harder. To my colleagues in neuro is easier.
Okay. I've had a lot of, it feels like getting into the neuro there, it feels like a brick wall. Even though I'm a Mayo patient, the only neuro I've been able to get into is because I have a neuro there, it feels like I can't get into any other neuro.
So they're a division under neurology. So anytime that your primary care doctor orders an X-ray test of your swallowing, it's done by them. And then you have a follow-up right after to go over the test. I think in your case that might be overkill. So asking your primary to say, hey, can you just order a clinical swallow evaluation for me? And they're going to have to probably write something in their order saying that you had a recent modified barium swallow study and there haven't been changes since that X-ray test. And then it's going to be probably up to the discretion of the speech pathology department, whether they feel like it should be repeated or if they feel like they can do a clinical bedside. And then you would see them and they could go over ideally the last study and then make a plan, because what I would stress is the importance of the time to spend with the SLP in that evaluation. A lot of times when these evaluations are done, because I've done these at other hospitals before, and there is very little information that we can provide to the patient at that time because we're booked like crazy. Whereas at Mayo, when they do the X-ray test of the swallow, they also have a 45-minute appointment scheduled to go over it in detail as needed.
Okay.
So the experience is usually a little bit better because of that setup. And it doesn't, from what I've heard from patients coming from other facilities, it sounds like that's not typical. And it was not typical before I came to Mayo. When I was at other hospitals up in the Philadelphia area, it was like I could come in and be like, it looked normal, and then I left, like everything's good, see you later. which is not ideal when you're dealing with something that's a mild, what is considered a mild issue on an X-ray test, but is a significant functional issue. And there are things that can be done to strengthen those muscles, but swallow is like this much of what I do at Mayo, whereas voice and upper airway are like this much. So I depend very much on my colleagues over in the neurology department to kind of help out with the swallow piece, since they see a lot more of it than I do.
I have way more swallow issues.
Yeah.
Like I have a little bit of voice issues, but my voice issues are more related to, I have essential familial tremor stuff. And so that's not up your alley at all.
Well,
or if it is,
tremor. Vocal tremor is usually treated by my laryngologist more than it's treated by me, but vocal tremor can bring on muscle tension as well. So, you know, EDS plus tremor is not going to be the easiest thing to treat, but it's something that is treatable to some extent. If the tremor ever gets really bad, Botox injections are actually pretty effective at kind of smoothing the tremor a bit, and then therapy to get rid of muscle tension in the interim.
Definitely get voice fatigue. The fatigue gets really bad. But
yes. And the fatigue is because you're using extra muscles that aren't meant to be used for voicing, probably. Yeah.
Oh, you've been so helpful.
I'm so glad.